And now we start with the scientific program, as you may see. So it's my pleasure to ask Gerardo Finocchiaro to the podium. Gerardo Finocchiaro, for the few of you that don't know him yet, he's one of the most emerging, outstanding scientists and working in the London with the Sanjay Sharma team, together with the other very well-known scientists, Michael Papadakis, Malhotra, and others. They are responsible for a lot of data that now we have, and I asked him to start with the key point of the lecture, that is the incidence and causes of sudden death in athletes. Gerardo?
Thank you very much, Professor Pelliccio, Professor Spataro, for the kind invitation. I'm a cardiologist. I work at St. George's Hospital in London. And first of all, I would like to say that this is a course, so it is interactive. Please, if you have any question, feel free to raise your hand and ask your question. So in the next 20 minutes, I will discuss with you a few topics. So first of all, we will review together the epidemiology of sudden cardiac death in sport, and we will identify possible high-risk populations. Then we will discuss the main etiologies that are implicated in sudden death in athletes, and we will discuss prevention strategies. So we said from the previous presentation that there are some divergent data about the epidemiology of sudden cardiac death in athletes, and we all know that sudden cardiac death in athletes is considered to be rare, but it is relatively rare, and if the question is how rare it is, there are really divergent data according to different studies and the different cohorts that have been studied. So we have numbers ranging from 1 in 50,000 to 1 in 300,000. So an extreme variability according to the cohort studied. Are there high-risk populations? This study from the Harmon and Dresner group in Seattle, which collected data on a national basis on NCAA players, so college athletes aged between 19 and 23, showed that basketball players seems to be at high risk. So basketball players had an incidence of sudden cardiac death 1 in 5,000 athletes per year, so a very high risk of sudden death. On the other side of the spectrum, we have this study from the Minnesota State in the United States, which showed, and this was on a different population, so it was athletes of age between 15 and 18. They showed just full sudden cardiac death during a span of 20 years. So here we had an incidence of 0.24 over 100,000, so roughly 1 in 300,000. So big differences. We have to remember something that I think is very important. So sudden death doesn't concern only high professional athletes, but regards all athletes, competitive athletes, recreational athletes. And of course, we hear most about high-profile professional athletes because they make it to the first page of the newspapers. But really, it is a phenomenon that regards all type of athletes. What about etiologies of sudden cardiac death in athletes? So I think that most of you probably know this pie chart, which shows that hypertrophic cardiomyopathy is the most common cause of sudden cardiac death in athletes. And this evidence comes mainly from the work of Barry Maron's group in the United States, which show that indeed this disease is highly prevalent in a cohort of sudden cardiac death in young athletes aged less than 39. And we know that hypertrophic cardiomyopathy is probably the most common inherited heart disease, a prevalence of 1 in 500, defined by the presence of unexplained left ventricular hypertrophy. So, as I said, these studies in some way show that in the United States, hypertrophic cardiomyopathy is the most common cause of sudden cardiac death in athletes. However, in the last 15 years, there has been various studies that in some way showed different results. So, for example, this is an Italian study from Professor Corrado's group in Padova, which showed instead that in the Veneto region of Italy, arrhythmogenic right ventricular cardiomyopathy is the most common cause of sudden cardiac death in athletes. And we know that AIVC is a relatively common inherited heart disease characterized histopathologically by fibrofatty replacement of the right and or the left ventricle. This study from Eckert from the United States, and this was a study on military personnel in the United States, and showed instead that in young athletes, sudden unexplained death or sudden arrhythmic death syndrome, which in other words means normal heart at the post-mortem coupled with normal toxicology screen, was the most common cause of sudden death, 41%. I already cited this study from Harmon and Dresner in Seattle. This is, as I said before, it's a national study on sudden death in NCAA players. And again, in this cohort, sudden unexplained death, which again means sudden arrhythmic death syndrome, so normal heart and normal toxicology, was the most common cause of sudden cardiac death. And we see here that hypertrophic cardiomyopathy accounted for only 8% of the cases. Recently, we tried to investigate the causes, the etiologies of sudden cardiac death in athletes at St. George's Hospital in London. At St. George's Hospital in London, we are very fortunate because we work with Professor Mary Shepherd, who is an expert, internationally renowned cardiac pathologist with a particular expertise in sudden cardiac death. And we receive hearts from all over the United Kingdom, and the lab receives roughly 500 cases of sudden cardiac death every year. And we try to investigate the causes and circumstances of sudden cardiac death in a cohort of athletes reported by an expert cardiac pathologist, Professor Shepherd. And we wanted also to report on the contribution of relatively novel entities as idiopathic fibrosis and idiopathic left ventricular hypertrophy. And this is what we found, and it was a cohort of 357 athletes, and the most common cause of sudden death was sudden arrhythmic death syndrome, accounting for 42% of the cases. And also we showed that if we consider the different age subgroups, so we see that SADS was particularly prevalent in individuals that died less than 18 years of age, while with the increase in age, cardiomyopathies were more prevalent. So I think that various studies and also some other studies that I didn't cite for brevity showed us that in reality hypertrophic cardiomyopathy doesn't equate to sudden cardiac death in athletes, but hypertrophic cardiomyopathy is a possible cause of sudden cardiac death in athletes, and probably the question is much more complicated than previously perceived. Sudden death in athletes is due to various causes, as sudden arrhythmic death syndrome, as arrhythmogenic right ventricular cardiomyopathy, idiopathic LVH, dilated cardiomyopathy, and maybe hypertrophic cardiomyopathy is not the most frequent. The data from our study, which showed that SADS is the most common cause of sudden death in athletes, has been replicated in this study that was published in New England Journal of Medicine last year. This study is from an Australian group, Professor Samsarian group, and this was not a study on sudden death in athletes, but was a study on sudden death in young individuals aged 1 to 35. And what they showed is that unexplained sudden death, in other words, SADS, was the most common cause of sudden death, accounting for 40% of the cases. of course, we have to remember that many studies showed different etiologies of sudden death in young athletes, but in young athletes, the contribution of channelopathies and cardiomyopathies of inherited cardiac disease is, of course, predominant. But if we consider athletes age over 35, probably coronary artery disease is the most common cause of death. So if we want to summarize these first few slides, we can say that there is an extreme variability in the epidemiology of sudden death in athletes. Possibly young basketball players are at risk. There's a relatively high prevalence of ARVC as a cause of sudden death in Italy. Extreme variability in general in the etiology of sudden cardiac death in athletes. SADS or SUD, or sudden arrhythmic death syndrome, or sudden unexplained death is an important cause of sudden death in the young and in athletes. And also another important point is that sudden death is more prevalent in males with a ratio of 9:1. So, of course, when we assess an athlete with a possible heart disease, we are very concerned because there may be triggers to sudden cardiac death that are related to sport. And a normal individual, an individual that doesn't have a cardiac disease, can really tolerate very well a lot of changes, physiological changes that are due to sport, like dehydration or adrenergic surges, electrolyte imbalance, or acid-base disturbance. However, these changes are not well tolerated by individuals with a cardiac disease, and this, of course, may be triggers for sudden cardiac death. So what can we do as a society to prevent sudden cardiac death in athletes? As we said before, sudden death in athletes usually occurs in previously asymptomatic individuals. So screening in apparently healthy individuals is a possible way to identify athletes at risk. One important question is, does cardiac screening save lives? And I'm sure that most of you have seen this slide. This is from a study from the Padova group in Italy, and this study showed that from when the law in 1982 made mandatory screening with ECG in athletes, we have witnessed a significant decrease in the rate of sudden cardiac death in athletes, from 4.5 per 100,000 to 1 to 100,000. However, there are different results, and this is a study from Israel, which instead showed that there is no difference after implementation of policies for cardiac screening in athletes in terms of sudden cardiac death. There are different models, as we have seen previously from Professor Spataro's slides. This is the Italian model, which includes ECG on top of physical examination and personal history. Then there is the American model, which is based instead on the AHA 14 points, which is basically personal history, family history, and physical examination, no ECG. And then the UK model is not really a model, I would say. There are professional athletes that screen through respective international organization protocols. Charities offer screening. I work for a charity that is called Cardiac Risk in the Young, which offers screening to both athletes and non-athletes. But the screening is not compulsory for non-professional athletes. So it's a big dilemma. As we've seen before, there are some doubts about the possible use of screening. So to screen or not to screen, there are doubts related to sensitivity of screening, specificity, ethical hurdles, and cost effectiveness. So this review came out on the BMJ in 2016, and in some way said that screening may be not effective for various reasons in athletes. So what are the concerns relating to ECG screening? The first is that there is a low incidence of sudden cardiac death, and we've seen before that, however, there are various data and different numbers according to the studies. And these are data related to the prevalence of cardiac disease that are diagnosed during screening program. Roughly, in our experience, it is 0.3% of detection of cardiac conditions that have the potential to cause sudden cardiac death. High number of false positives, and we will discuss this very deeply. The ECG in athletes is different from ECG in non-athletes because there are several changes, several alterations that are due to cardiac adaptation, so to increased vagotonia, bradycardia, AV block, repolarization abnormalities, chamber enlargement, and this may be a cause of challenges for the doctor, for the physician that is assessing this ECG, and may be a cause of increase in false positive. In other words, decrease in specificity. However, and I'm sure that we will discuss this deeply in the next presentation, there has been improvement in the last 10 years in terms of specificity of the ECG interpretation and a significant reduction in false positives. There are also concerns relating to false negatives. So we are not able to identify all cardiac conditions that may cause sudden cardiac death with an ECG, unfortunately. So, for example, we can have false negatives that are anomalous coronary arteries, and unfortunately the ECG is normal in this condition. Premature atherosclerotic coronary artery disease, especially in over 30s, and again, ECG absolutely normal. Or adrenergically driven ion channel disorders, for example, CPVT. The CPVT, the ECG can be absolutely normal. Or incomplete expression of cardiomyopathy. Or we can have acquired conditions, for example, myocarditis or commotio cordis or electrolyte disorders. Then, of course, there is a concern about cost. Because, of course, the use of ECG, the cost may be very different according to different countries. But also the cost is not only the ECG, but it's also related to the numbers of tests that we are asking for an ECG that we consider abnormal. And this is a study that we recently published on the Journal of American College of Cardiology from our group, and showed, first of all, that the use of the revised international recommendation for ECG interpretation in athletes reduced significantly the false positive, and 0.3% of conditions that can potentially cause sudden cardiac death were identified with all three criteria, so also with the international criteria. And the second important point was that the use of the refined criteria of the international recommendation reduced significantly the cost of the whole program. Why? Because basically the international criteria, the refined criteria, have the rate of false positive is less. That means that we are referring less people for tests that are not really required. So this translated in a 21% of cost reduction. And of course we can use these savings to do other things, for example to screen additional athletes or to buy AEDs at the sport arenas. So I want to conclude with some take-home messages. First of all, sudden cardiac death is rare. We have seen that there is an extreme variability in the epidemiology of sudden cardiac death in different cohorts. It's always a tragic event because usually it regards young individuals with significant loss of years of life. We have said before that there is a significant variability in the epidemiology and also the etiology of sudden cardiac death in athletes. I would say that until probably 10, 15 years ago, hypertrophic cardiomyopathy was considered as the most common cause of sudden cardiac death in athletes, and I think that recently we have other studies that showed something different. Cardiac screening is a possible way to identify individuals at high risk of sudden cardiac death. Specifically, cardiac screening with ECG is particularly accurate to identify these individuals. is the best tool to identify these individuals. We have to remember that, however, there are some concerns related to costs, related to false negative and false positives, and also ethical hurdles. Thank you very much for your attention. If there are any questions.
Thank you, Gerardo. Stay here for eventually some questions, some consideration from the people, from the audience. Just waiting for someone. I would make a comment and a question for you. So you actually destroyed the one we had, what we believe for true, that structural cardiac disease were responsible for sudden death, particularly cardiomyopathies, particularly hypertrophic cardiomyopathies. Now, your study and the other studies suggest that the vast majority of the young people die and we don't know why. So, which is your feeling?
So I think, first of all, I would like to make a couple of comments about the way these studies have been designed. And first of all, I think that the study from Maron's group have been, of course, very informative. However, they are based on autopsies where the post-mortem examination was not made necessarily by an expert cardiopathologist. And I think this is a very important point because the assessment, working very close to Professor Shepard, I learned quite a lot. And I think that from a histopathological perspective, this is a very, very complex job. It's very difficult to assign a cause of death to young individuals that die suddenly. There are a lot of gray areas, much more than probably in sports cardiology. So I think it's a very, very difficult task, and probably a person that is not trained to do this all the time and to do only this can very easily, in athletes that, as we all know, have physiological hypertrophy of the heart, assign this physiological hypertrophy as a cause as hypertrophic cardiomyopathy, while instead it's a normal cardiac adaptation and it's not hypertrophic cardiomyopathy. And I think in this setting it's very important to also do histopathological assessment of at least 10 blocks, which we do at our center, which of course is very important to identify myocardial disarray, which is a pathognomonic for hypertrophic cardiomyopathy. Regarding our study, it has the limitation that there is a referral bias in the sense that we receive a lot of cases of sudden cardiac death in especially in young individuals. However, we don't receive all the cases of sudden cardiac death in the United Kingdom. But we receive more than 500 cases per year, so it's a significant numbers. Regarding your last question, what is the cause? So in our cohort, we had 42% of individuals with a completely normal heart, normal toxicology. I think that probably in these cases, the cause of sudden death was a primary arrhythmia. So these were individuals that had conditions where the heart was structurally normal, but probably inherited condition where the main problem was the electrical system of the heart, but not the structure or the function of the heart.
Okay, thank you. Which means, as a final consideration, that number one, we have to teach pathologists how to do a pathological examination in athlete's heart, because also this is an experience in Italy and most countries. The forensic pathologists, what we call in Italian medico legale, they are responsible for pathology for most of the cases, and they actually don't know. Yeah. So this implies that this educational effort that we are doing for team physicians should be done also for pathologists. Number two, the need for a protocol, for a kind of international protocol for doing pathological testing in case of athletes. Well, thank you, Gerardo.